work for me. So, but I'm going to talk today about primary aldosteronism, but I'm not going to talk about things that I already knew. I'm going to talk about some new things I found in reviewing the recent literature in the field that I thought were interesting, and I hope you'll find are interesting. And I know that how I can measure if you find it's interesting or not, and that's by how many people are looking at their cell phones. And so that's the easy measure. But because of this, because I'm going to talk about the new things that I found out that I found interesting, and I hope you'll find interesting, I'm not going to talk about some things that I already knew about, that I've talked about before. So I'm not going to talk about how does primary aldosteronism make the blood pressure go up. I found that boring to me, and if it's boring to me, I can't make it exciting for you. So I'm not going to talk about that. If you have questions about it, come and talk with me. I can talk all day about it. I'm not going to talk about how to screen for primary aldosteronism. I've talked about that before, and all the same considerations go. It's a boring subject for me, and so I can't make it interesting for you. And the other part of that, what's the definition of a bad talk? My definition of a bad talk is one that makes me feel dumb on one end and numb on the other. And so there's going to try to avoid those considerations. But I'm not going to talk about how to definitively diagnose primary aldosteronism, because that makes me feel dumb on one end. And I'm not going to talk about how to treat primary aldosteronism, because that's pretty easy. If it's unilateral, take out the gland. If it's bilateral, treat with blockers. If you're going to treat with a blocker, use spironolactone because it's twice as effective as a Clarinone. And finerenone is not even worth trying. So I'm not going to talk about these things. I'm going to talk about a variety of things that I thought were somewhat interesting to me. I hope you'll find them interesting. And so then, they say, you should summarize your talk and tell people what you're going to talk about. And so I'm going to try to talk a little bit. I'm going to assume, that aldosterone activates the melanocorticoid receptor that suppresses renin release. But if you have the development of autonomous aldosterone production, and that gets worse over time, if it gets worse over time, it means that primary aldosteronism is not a dichotomous variable. It's not something you either have or you don't have. There's a continuum. I hope when you come out of here today, you'll say it absolutely is a continuum, and I don't need to worry about whether somebody has a specific diagnosis or not. And then finally, that it has adverse effects, here we go, on high blood pressure, cardiovascular disease, and on the kidneys. And if we treat it right, we can help prevent those. So the first thing is really, how frequent is primary aldosteronism? And this has kept going through phases. When Kahn first figured out about primary aldosteronism, he said it affected a lot of people. When I was a renal fellow, back in the dark ages, I did not diagnose or see a single patient with primary aldosteronism in 3 years of renal fellowship at a pretty reputable referral institute for nephrology. Okay? And yet now we see it all the time. And so how frequent really is it? And that's a hard question, because you can only tell how frequent it is if you screen people for it when you don't think they have it. And that's a hard thing to do, but there's a paper that came out that did exactly that. And so they took data from 5 different studies at 5 different places, major places looking at hypertension and doing research on it. They recruited patients with variable degrees of high blood pressure, and they specifically recruited people in various different degrees of high blood pressure. And then they did them because they wanted to investigate the hormonal mechanism of their blood pressure. So these were people with varying degrees of blood pressure control, recruited for a study of what caused your blood pressure to be where it is. And every patient completed the same protocol. They included an oral self-loading, and then looking at including things like plasma aldosterone and plasma renin, calculation of their aldosterone to renin ratio. And the first data I'm going to show you is their urinary aldosterone while they're on a high salt diet. They had to document a 24-hour urine sodium excretion of over 190 millimoles per 24 hours. So presumed suppression of renin and presumed suppression of renin and angiotensin II dependent aldosterone production. And so here's the first. These are the patients who have treated resistant hypertension. And each bar here, and it's hard to see because there's so many bars, but these are individual bars. Like you can see there's one bar, there's another, and there's another. Is the 24 urinary aldosterone. None of these patients had been previously diagnosed or even screened by their doctors as having primary aldosteronism. If they had a diagnosis of primary aldosteronism, they couldn't be recruited into this study. Now, this dotted line here is 12 micrograms per day of urinary aldosterone excretion. That is the established cutoff of normal versus abnormal. Look at this. A heck, a lot of these patients with treated resistant hypertension have urinary aldo levels that are sky high that meet the definition of primary aldosteronism. Okay, well, that's interesting. Yeah, and that's not too surprising. Lots of studies say that in patients who meet the criteria for resistant hypertension on 3 drugs at reasonable doses in the right classes, if you meet that criteria, you have a 25 to 40% chance of having primary aldosteronism. And this goes exactly along with that data. What's a little strange is when they looked at people with untreated stage 2 hypertension, so they're on no medications that could affect anything here. Notice the number of these patients who have elevated urinary aldosterone levels. Look at patients who have stage 1 hypertension. Look at the number of these that have elevated urinary aldosterone excretion. I'll digress for a second. I think that any urine study that doesn't adjust for body size is flawed. Okay? There is no way that a urine study that looks at my mother, who is 89 years old and weighs 88 pounds, should have the same expectations for urinary excretion as for my son, who lifts weights and weighs about 100 kilos and has a 5% body fat. It is an oversimplification to look, in my opinion, to look at any urinary cutoff that is not adjusted for body size of the person. But these are the cutoffs that we have. But I'm sorry for my digression here. What about people who have normal blood pressure? What the heck? Look at all these people with elevated urinary aldo. These are normotensive patients. And so when they quantified this, they actually looked at them. Sorry, this is going from the other direction as the previous slide. It took me an hour to make the other slide look pretty and go in the way that I wanted it to go from the severe hypertension to the untreated. I ran out of time. So we go from the right. So this is looking at the percentage of people who had resistant hypertension who could be diagnosed with primary aldo from the urinary aldo excretion with different cutoffs to the urinary aldo, because there is no perfect cutoff for urinary aldo. And so the standard one is 12 micrograms per day, 24%. If you used a more liberal definition, and many patients who have unilateral autonomous aldosterone production will have 10 micrograms a day or even less of urinary aldo excretion. But if you look at these, I mean, there you go up to 28%. And if you have a very conservative cutoff, it is 15%. All right, that's a pretty substantial percentage worth screening patients for every patient resistant. And that's not new. Well, here's patients with stage 2 hypertension. Nobody would be saying we ought to be screening all these patients. And you look at this, at the standard criteria, 21% have excessive aldosterone production. It's renin independent. With stage 1 hypertension, 16%. 1 out of 6 patients with stage 1 hypertension. Is anybody screening all the patients in primary care who have stage 1 hypertension for primary aldosteronism? I don't think so. Now, here was really one here were the normotensive patients. There is evidence in normotensive patients that, depending on your criteria, anywhere from 1 in 20 to 1 in 7 have evidence of autonomous aldosterone production. Mm-hmm.
Is it okay to ask?
Absolutely. At this point, it talks about you, not me. So ask away.
I'm just curious whether is is it a reflection of whether like 190 millimoles of sodium, is it enough to suppress the renin aldo, or is it like by what standard is considered high?
Under 90 is actually what's the cutoff for saying that, oh, they're salt loaded. So these were on salt loading protocols. So yeah, and they didn't correlate, they didn't report the renins. They did say as a group the renins were suppressed in this.
Do you know the Aldo assay that we do in the modern era? And I know you have talked about it before. How does it differ from the assays when we establish these traditional? Are they different? Are there different sensitivity to these assays? How do they differ in terms of compared to when we establish these cutoffs?
Yeah, that's a great question. Have the assays changed? I haven't seen anybody talk about the assays changing, having different sensitivities. Now, what I'll show you is, turns out that possibly the urine aldo is not the right measurement of urinary aldo.
Which was my third question.
So let me go on to that. So it turns out that the urine aldo, which is an acid aldohydride metabolite, is only a minor metabolite of aldosterone production. And the better one is something called urinary tetrahydroaldosterone, which represents about 35 to 40% of total daily aldo production. I'll show that these correlate pretty well.
My question was slightly different, which is,
okay,
and if you don't mind, which is like in a feedback loop based hormone, is it reasonable to sort of say that cutoff will define the diagnosis versus the true hyperaldo is actually the aldo responsive or aldo inhibition or aldo removal responsive? So is this just a cutoff based diagnosis? Should aldo always be a cutoff based diagnosis? That's the question.
So for the question of should there be an absolute cutoff for the urinary aldo to diagnose urinary aldosteronism? And my answer to that is absolutely no. To me, it's similar to saying you're overweight if your BMI is more than 25. So it means at 24.9 BMI, you're not overweight, but at 25.1, you are. And 25.1 is the same as 50.1. No, I absolutely believe, and I hope one of the things you'll take out of this is that this is not a dichotomous variable, you either have or you don't. I think there are gradations of primary aldosteronism. Does that answer the question?
Partially, yes.
Partially. Now here's the question that I really want to go at. What should we do about these people who have evidence of primary aldosteronism? I define primary aldosteronism. Well, maybe rephrase. Who have evidence of autonomous aldosterone production, not being driven by renin, and presumably not being driven by hyperkalemia. Should we care? That's a tough question. But here was a study. This was the Cartagena study. I don't know if Ashutosh, if you're familiar with this. This was out of Canada, and it was designed to evaluate the determinants of chronic disease among the general population. They had 10 years of follow-up, and they had 20,000 people enrolled between 40 and 69, mostly pretty healthy people, picked to reflect the demographics of Canada. Okay, turned out 2,000 of them had baseline aldo and renin measurements of dietary assessment of their sodium and potassium intake. They have 10 years of follow-up. So now they can say, is there a correlation between the aldo and renin and what happens to adults over the next 10 years? Okay. So here's the simplistic sign of results. First of all, and so this is the crude hazard ratio for major adverse cardiac events, and this is adjusted for their age, their sex, their blood pressure, because you might say, oh, maybe these people with autonomous aldo production have higher blood pressure. This is adjusted for their blood pressure, their 24-hour dietary sodium intake, use of RAS inhibitors, renin inhibitors, mineralocorticoid antagonists. Okay. If you look at either crude or, here's adjusted for these things. The aldo concentration 1.33, higher or low, that makes sense, except look at the hazard ratio, it crosses 1, so it's not significant. doesn't add anything. Same thing for the adjusted aldo. Okay, oh, and these are all log transform variables because obviously a ratio of 100 is not 10 times worse than 10. It's probably anyway. But notice here for the renin, higher renin resulted in a lower risk of cardiovascular events. 60% fewer events. If you adjusted for all these things, still remained borderline significant. And the ARR was, but that was being driven by the renin. So let me
Is
just,
this per millimoles per liter of aldosterone, like what, like the unit of 33% increase risk, or 57% increase risk of MACE for aldosterone concentration, is that per what of aldosterone?
I don't remember, but let me show you a table
Okay.
that, or a figure that I think will answer that question better. I.e., is this a dichotomous or is this a graded association? So, all right, so here's now doing a cutoff. This is not answering your question, but we will get to your question in a second. And this is just looking at for a renin. Now, this is 4 nanograms per deciliter. Turns out they use a different unit. Divide this by about 6. So this is a renin of about 0.6. And so either oh, I think I typed these in and I typed this in wrong. I'm sorry. No, this is correct. If the renin is suppressed, less than 0.6, the adjusted cumulative index of major adverse cardiovascular events, and again, adjusting for the things like blood pressure, potassium. God, over 10 years, that's a 2.5 to 2.12 higher risk using a cutoff of 0.6 in our current data set. If you use the ARR, and fellows in clinical know I don't like the term ARR because in most cases being driven by the renin. But if you use that, you get the same difference. This is not an aldo-dependent thing, correlates with the renin activity. And if you say that, well, this show me the continuous. So here's the outcomes. This is major adverse cardiovascular events based on the renin at entry. And notice that as you start, here's a renin that's 20, so that's about 2.5 or 3. As that decreases, the risk of major cardiovascular events goes up in a fairly continuous pattern. There's a minimal change here with very high renins. I wonder if that's being driven by people who have some degree of heart failure or liver disease or other things that cause high renin levels. If you look at the aldosterone, this is in picomoles, divide this by 27.7 divided by 30. Let's say, yes, as you have higher aldosterone levels, but we don't have anything that directly treats aldosterone yet. I know ASI's aldosterone synthase inhibitors are coming. They lower it by about 50%. But you can see in the ARR. So this really looks like it's a continuum. This is major cardiovascular events. We're nephrologists showing kidney-related events. So here's the chance of a rapid kidney function decline, more than 5 mils per minute. I think our conclusion, and we really see the same thing here. As the renin goes down, the risk of worsening kidney function goes up. Remember, this is a healthy young population. None of them have a diagnosis of primary aldosteronism. The evidence of primary aldosteronism, whether it's a high ARR or a suppressed renin, it takes worsened renal outcomes. You say, well, this is a pretty strange diagnosis. How about a different one? How about a 50% or 40% decline in the eGFR, development of kidney failure? It's the exact same results, okay? And so increasing evidence that asymptomatic primary aldosteronism leads to adverse cardiovascular events over time. And maybe it's something we should be worrying about routinely in our patients. So what I've tried to tell you about so far, this is a segue. It means I'm getting ready to tell you about something completely unrelated to this. So primary aldosteronism is surprisingly common. Now, I would make the argument that we need to much more aggressively screen for primary aldosteronism in nephrology. I think I can make a good case, not with enough data to show that to prove that it's beneficial. But I think that I can make a case that every patient being referred for CKD should be screened for primary aldosteronism. Certainly everybody referred for uncontrolled hypertension should be controlled for, and I'd recommend, and even I can make the case, everybody referred for kidney transplant should be evaluated for primary aldosteronism. I make a case for all that we don't have the trials to prove that I'm right. That's my bias, but it's common, much more common than anybody would expect. And its subclinical forms are associated with bad long-term outcomes. Oh, whoops. So that's a summary so far. Any questions before I go into the next thing I thought was interesting? All right, the next thing is that we have learned better how to identify what caused primary aldosteronism. And that's because we now have an antibody, a monoclonal antibody, so it can be made in unlimited amounts forever. It specifically reacts against aldosterone synthase. That's also called CYP11B2. That's the name of the gene, but this is the rate-limiting enzyme for aldosterone production. And we can use that on adrenal glands to see where are the cells that are making aldosterone. It's typically an on-off, either making or not making it. And we can do this, we can combine it with routine H&E to understand what is going on in an adrenal gland. So here's adrenal gland taken out from a patient with primary aldosteronism. Had a mass, they had an adenoma on CT scan. This is what the H&E looks like. I will tell you that there's no way to tell whether this is aldoproducing or not, unless you do immunohistochemistry or CYP11B2 for aldosterone synthase, the rate limiting enzyme for aldosterone production. We can tell exactly what cells are making aldosterone. And so here it is. Here's the adenoma. Matter of fact, what you can see is in the zona glomerulosa, which is the very outer rim of the adrenal gland. It's been turned off. They're not making aldosterone. So presumably these patients had high aldo levels that led to low renin levels, led to low angiotensin II levels, which led to absence of aldo-stimulated renin production, of angiotensin II stimulated aldosterone production. Now, here's a non-functional adenoma, and there's no way to tell it's non-functional. This was taken out of a patient who had primary aldosteronism, had lateralization, they had an abnormal CT, and they went for surgery, took it out. And this adrenal gland and this histology looks exactly the same as the previous patient. You can only tell that it's non-functional because when you do the staining for aldosynthase, it's not in the nodule. And you can see the residual aldosynthase expression around here. Okay. This has now become state-of-the-art, should be routine part of the evaluation of any adrenal gland taken out on the patient. And it is being done here. I think they send it out, but they get the results back. But it's a trivially easy statement to do. Now, for the patient who does not have an adenoma, we call, they have diffuse adrenal hyperplasia. And this is what you would look at and say, but it's strange because if you do the CT scan, you never see a hyperplastic adrenal gland. Isn't that strange? There's no hyperplasia. If you do H&E staining, there's no hyperplasia of the zona glomerulosa. What you see, though, is just this diffuse linear expression of aldosynthase around the entire adrenal gland. And it seems to be a little bit more intense, but that's hard to quantify. It turns out that's not what you see in the majority of patients who have bilateral autonomous aldo production. What you see is something that looks like this. You see nodules, and they may be micronodules. And so here you can see, here's a nodule. How do you differentiate a nodule from an adenoma if it's less than, a nodule adenoma is more than 10 millimeters, a nodule is 9 millimeters or less, what crazy arbitrary differentiation, but what you can see is there it is. You know, this sure looks like a nodule in this adrenal gland. But notice most of it does not make aldosterone. And histologically, there's almost no way to tell the difference without seeing. And then very often what you'll see is that they may be micronodules, very small nodules, 1 millimeter or less, and the patient may have multiple micronodules in these adrenal glands. This is the primary cause of bilateral autonomous aldosterone production, is these micronodules. It is not some funky microplasia of the adrenal gland. It is the development of autonomously aldosterone producing cells in the adrenal gland.
Good one. I'm so sorry. Just to go back to your 2 slides, there is, so you're saying the diffuse adrenal hyperplasia, when you see it from a pathological perspective, it's not really existent. It almost always turns out to be this micronodular bilateral hyperplasia. Is that a correct way to say it?
Right. Perfectly summarized.
Thank you. Sorry.
So I think, I'll say at the end, we should stop using the term bilateral adrenal hyperplasia. But it should be unilateral or bilateral autonomous aldosterone production. That's what we're looking for in patients.
Are there hyperplasias that are not producing anything?
It-
Is micronodule always associated with hyperplasia or not? That's my question.
The question is, can you have micronodules that give unilateral aldosterone production? And the answer is yes.
Without having hyperplasia.
Without having hyperplasia, yes. And that's part of it. Here's, I call it the 20-20-20 rule of primary aldosteronism. And one of the 20s in there is 20% of patients who have a CT, who have confirmed primary aldo. 20% of the patients who have a CT scan that shows no adenoma. 20% if you do adrenal vein sampling will have unilateral aldosterone production.
And no hyperplasia. And no adenoma.
hyperplasia.
In those cases that lateralized, with hyperplasia cases that lateralize, if you do a adrenalectomy, what's the chance that you get autonomous production on the other side?
Great question. That was one of the things that was very interesting, but I took it out of the talk for sake of time. But the answer is 50% chance of development of recurrent disease in the other adrenal gland. And it's really based on this and the data that if you have primary aldo, you have unilateral disease, and you have it taken out, you cannot be considered cured for life. If you have an adenoma, you're more likely to be cured for life. But if you have these micronodules, and you can certainly say whether could they develop in the other gland, there's a 50% chance of recurrence. Now we tell you is that these micronodules are common in people who do not have a diagnosis of primary aldosteronism. Okay. Remember, I told you a lot of people who don't have a diagnosis of primary aldosteronism have primary aldosteronism. And this may be why. So this was adrenal samples from renal transplant donors. Now, I'm assuming that these were deceased donor renal transplant donors, but they didn't say, but I can't imagine with the living that they took out the adrenal gland. Okay, because how are you going to look at it? Lots of adrenal glands. So, and they did immunohistochemistry for CYP11B2, and what they saw, lots of these micronodules. Okay, here's a patient who had just a little bit of normal zonal glomerulus and a lot of micronodules. They look huge. Here's a bar scale that says that's about 1 millimeter. And the size of it has many micronodules in these. And if they actually went and looked and said, gosh, is this a fixed event or is this worsening with time? Are people developing more nodules and bigger micronodules as they get older? The answer is absolutely they are. So here was in their 44 samples, a variety of ages from 10 to 70. This was the time they called them aldosterone producing cell cluster. The new term is aldosterone producing nodule. An increased number, there tended to be more in females than in males, but as we were fortunate enough to celebrate more birthdays, they developed more and more of these nodules. Are they doing anything? Oh, how about another study? You know, this is correlation, more correlations show the same thing. So there's a study from Japan, 837 autopsy cases. They excluded everybody over 65, everybody who had hypertension. Everybody who's on antihypertensive drugs, everybody had adrenal tumors, and everybody who's on steroids. Okay, we say, what's the frequency of these aldosterone producing nodules? They had 107 adrenal glands. There we go. 30% of them had at least one APCC. And here was a graph that they showed of the number of APCC, aldosterone producing nodules, as it correlates with age in patients. Okay, as we got older, we had more of these nodules being present. Now, I took this data and I recalculated because I thought this is a funky way of presenting it. So let me show you this data in a slightly different manner. This is, and the blue bar here, the number of adrenal glands, and I did it by decade of life. So a pretty similar number in each decade of life. The orange line is the percentage of adrenal glands that had aldosterone producing nodules. Pretty substantial increase over time to where close to most people, once you got to the Medicare eligible age range. Okay. So these are, and again, these are people who are normotensive and we're not taking any medications.
Yes. I mean, this one confuses me because isn't the very sort of purpose of diagnosing adrenal producing nodule to some extent is the manifestation of hypertension. So why, if I want to interpret it as this is a variation of normal, that some aldosterone producing mechanism over the life may convert into focal regions in nodular patterns rather than an autonomous pattern, which is responsible for a disease phenotype. How do I sort of come out of that particular interpretation? Given
A couple more slides.
Okay.
I think I'm going to answer that.
Fair
for you.
enough.
Okay. Now then, they did look at these nodules. So now once you have immunohistochemistry, you can dissect out, or the immunohistochemistry, you can dissect out the nodule. And you can do genetic testing on the nodule separate from the normal adrenal gland. And what they find is that a substantial percentage of these adrenal glands have mutations that are known to cause increased aldosterone production and to lesser extent hyperplasia of adrenal gland, of adrenal glomerulosis. So INCA 1D is an L-type calcium channel, lets calcium into the cells, you increase intracellular calcium, turn cells on, and they do more of what they're going to do. And that's the most common genetic mutation in these adrenal aldo producing nodules. There's a little bit of ATP2B3. It is a calcium ATPase, so it's not taking calcium out of the cell. So intracellular calcium goes up. There's ATP1A1 is actually NAKTPase. If you get abnormal NAKTPase, you have abnormal amount of sodium in the cell that leads to sodium calcium exchange, leading to an abnormal amount of calcium in the cell. And this was no detectable mutations, but that's only the genes they knew to look at. More and more evidence says, now this data is from 9 years ago, is saying that almost every nodule has a detectable genetic mutation. And when they tested the normal, adjacent normal adrenal gland, that mutation was not in the adjacent normal adrenal gland. This is an acquired somatic mutation that leads to the development of autonomous aldosterone production. How about another one? Here was from Georgia Regents. They did another one. This again is a young kid. This is going to get to your question a little bit. Here's an older person. Okay, notice the younger kid had to be the classic appearance of where aldosterone should be. It should be in the zone of glomerulosa. Around the outside of the adrenal gland, it looks perfectly normal, and there's what it looks like standing for aldosterone. Here was a typical 53-year-old woman, loss of that continuous pattern, and the development of these micronodules. Here's one, two, a third one in this patient. Now, what they then did is correlated the size of these nodules with age. Notice the size of the nodules. A lot of people had no nodules, but people who did, they got bigger with age. This was the total amount of CYP11B2, the amount of aldo-producing cells as a proportion of the adrenal cortex. It goes down with age, which suggests that perhaps as you have more of these nodules that are inappropriately producing aldo, that the normal cells are trying to compensate by making less aldo. And there's the data. Here was the data looking at the normal 11 CYP11B2 area. Took the total, subtracted out the nodules, it dramatically goes down. And the percentage of the total of the aldo synthase positive cells that are nodules goes up and up. So many people, you can have the development of these nodules. It may not have a clear phenotype, obviously, because of compensation with the decrease and the type of the decrease in the normal zone glomerulosa cells. If you have more aldo-producing nodules, it would predict that aldosterone secretion is less renin dependent. So obviously, I think that looks at that. So this was, in this same study, they had this data and they said, well, geez, that would be, so let's look at this. So they did oral salt loading. What they found is that if you did oral salt loading, renin decreased more as with people who had higher number of birthdays than in younger people. Aldo level did not change with age, but if the aldo level doesn't change, that means you have more, and renin goes down, it means you have more renin independent aldo production with age. And here's the graph that shows this. This is looking at it as the aldo-renin ratio. It's log transformed as is appropriate as a function of age. These were obviously not the deceased donors for these kidneys. These were a separate group of people that they recruited for this study. But there's clear evidence of a gradual increase in the amount of aldo-producing nodules and less renin sensitivity of the adrenal gland with aging. What causes these nodules? I hinted at it before. This is they took the tissue box, did the staining for CYP11B2, dissected out the nodules. They could do it from here were nodules in people who had primary aldo, who'd had a unilateral adrenalectomy. Looking at the adenoma, looking at nodules in glands that had an adenoma, whether functional or abnormal, and nodules in 60 and patients from deceased donors. Again, what you see is a large number of these nodules. And when they did genetic testing on these, again, now this study is from more recent, the first study I showed you is from 2017. This was published earlier this year. I think it was just in press. Anyway, here what they can see, here's that this calcium channel, major cause of these mutations. These other ones, a different calcium channel. This is interesting. This is a protein. What is it? Just had a Nature paper published about it. It's involved in cell adhesion. Turns out adhesion of one cell to another affects auto production by adrenal zone glomerulosa cells. They talk to each other. Now, this is very interesting. KCNJ5 is a potassium channel mutations in this are the number one cause of an aldosterone producing adenoma. The genetic cause of an aldosterone producing adenoma appears in general to be different than the genetic cause of an aldosterone producing nodule or microadenoma. And presumably, for whatever reason, the the potassium channel mutation leads to more stimulation of cell proliferation. And that's really the difference between micronodule and an adenoma is how much do the cells proliferate.
Can you
And
have
when they looked in this, to see stoner kidneys,
can you have both adenoma surrounded by micronodules,
yes, you can. Yes, you can. Those,
and then you have two genetic causes?
exactly. Exactly. And so to me, when I look at this and I say, these genetic causes, you're saying these are genetic causes, but you also showed me data that 6% of normal people have evidence of autonomous aldosterone production, and 25 or 30%. It tends to make me think that spontaneous genetic mutations are common in kidney epithelial cells. I'm sorry, this is not kidney, in zona glomerulosa cells. And can lead to, if this ineffective DNA repair mechanisms can lead to acquired genetic diseases. And if it happened in one gland, it can happen in the other. And it does seem that if you take all the data, I look at all the data and say, how common is an adenoma versus the micronodules, if we look at it and say, well, that correlates with bilateral disease, it's about 3 times more common than an adenoma. And to me, that these mutations, CACNA1D and the other ones I talked about, are more common than the KCNJ5 mutations that lead to an adenoma, which makes me think that absolutely could occur in the contralateral gland. And we now know there is data that says that if you have an atypical phenotype, which you have unilateral disease and you don't have an adenoma, you have a 50% chance of biochemical recurrence in the contralateral gland with time. All right, summary so far. Primary aldosteronism is common. Subclinical primary aldosteronism is associated or correlates with adverse long-term outcomes. We don't have the studies showing that we can prevent that with MR blocker therapy. Now, aldosterone-producing nodules are common. Their frequency increases with age, and I didn't show you that the most common cause of bilateral autonomous.
Question. So in the first few slides, when you showed the second sentence, which is subclinical primary aldosteronism, which is in the patient with normal tension and they still have more than 12 or whichever cutoff we take, did they try to correlate that with age, trying to put it in context of the second segment, and are those people with normal tension and have higher aldosterone level are the older people who have continuous mutations and age-associated hyperaldosteronism?
I'd have to go back and look at the things that they controlled for. Is it fairly, in the study that looked at the long-term outcome, that I think the age range that they enrolled people was between 40 and 60. So there's a fairly narrow age range with that. I think they controlled for age at time of entry, but I don't know for certain.
So even those patients where the aldosterone level is high, but they don't suppress the renin, so they're kind of more like an aldosterone resistant, so there's no response to in terms of renin suppression. The risks are lower in those cases, right? Where the renin does not drop, the cardiovascular and renal risks are less in those cases.
Well, so the patients with the higher renin are not being treated with MR blockers. Presumably that means, my interpretation is, that means they were less likely to have excessive MR activation. Okay.
So would you not treat those cases where the renin is not responding by being suppressed?
I've not shown you any data on people treated with MR blockers
Okay.
yet.
Okay.
Great segue.
Okay.
Other questions before the great segue. All right, and so I asked the question, should we retire the term bilateral adrenal hyperplasia? Should we replace it with bilateral autonomous aldosterone production?
So the hyperplasia that we find in imaging, the CT MRI, it's just that micronodules increasing thickness or just
I think it's the radiologist looking. You send them for primary aldo, I don't see a nodule. Oh, I remember from medical school, that means they have hyperbilateral adrenal hyperplasia. I think that's, I'd be shocked if a radiologist didn't have that in the back of them. But nobody says histologically the glands are hyperplastic. All right. Adequately treating primary aldosteronism improves outcomes. Okay, I've shown this data. This is comparing patients who have essential hypertension, the blue line, to people with primary aldo that's not being adequately treated. Cardiovascular risk after controlling for age, sex, and blood pressure and diabetes status. Cardiovascular event rate is, I think it was 2.8-fold higher. If you adequately treat, so now the question, and in here is that if you adequately treat them, the green line is primary aldo, where they're running above 1. This is one study. Now I took this many years ago, and I've been preaching that we need to treat to the renin greater than 1. But I always feel a little uncomfortable in basing that on one study. So here were more studies. And some of this is for the renal fellows when you're getting ready to take boards. Okay, because you're going to be asked in a patient who has unilateral autonomous aldosterone production, is medical therapy with an MR blocker as good as adrenalectomy? And when people will look at data like this, in Taiwan and a huge number of people, they've evaluated primary aldosterone. 858 patients with unilateral disease, 545 underwent adrenalectomy, 413 got MRB therapy. Here's their survival probability. That's a nice outcome. Boy, that looks better. I want my adrenals taken out. Okay. And if you look at long-term MACE-free survival, you see the exact same thing. This is not adjusted for how effective their MRB therapy was. But this is what will lead it so that for our renal fellows, when you take the boards and they ask you the adrenalectomy is equal to MRB, no, it's better. I don't believe it.
Well, also the people who have surgery will probably healthy
Exactly.
enough to tolerate surgery.
Exactly.
Selection
And so there
bias.
may be a selection bias, but let me even take their data a little bit further. So here is their data. These are the people with a high treated medical therapy with a high PRA, turns out more than 0.6, or a suppressed PRA, low. Well, here are the people who had the suppressed PRA. Here are the people who had the high PRA. Now, they put this data in a figure in a different figure. Now, I combined this figure with the past figure, and it took a lot of work in Illustrator to do this. But here's what I did, okay? And so here's plotting. So this line right here, this line right here, are the people who got adrenalectomy. This, and that was just their MACE-free survival. Now, here was the line for the people who had a PRA greater than 0.6, combining MACE and mortality. Looks just as good, if not better, and it included mortality into the outcome. And here was the curve for the people treated with medical therapy who continued to have a suppressed treatment. Okay.
It's showing, you go a couple slides back.
So,
Yes, this. No, the mortality. Yes. It's showing
they did not show mortality based on
40+% mortality.
Hmm.
So the black solid line shows 40% mortality and
yeah, well, 35% mortality over about 20.
all with the people.
I don't remember. I think there probably is certainly a selection bias. You know, if you're 82 years old and you get some medical frailty, and you can be autonomous, they probably didn't get them. They were probably not offered.
Yeah, I was wondering how we excluded the patients.
So this is not a prospective, this is not randomized. This is bad data, but it's the best available data.
Thank you.
All right, so for board exams, MRB therapy is not as good as adrenalectomy for unilateral autonomous autoproduction. I think this is overly simplistic and does not consider the benefits of what I term renin-guided therapy. I think should be the treatment, it should be how primary aldosteronism should be treated.
Plus the fact that you said 50% of those who have unilateral later on will develop the other one. So then going through all those surgery and others may be even less worth it.
Yeah, well, that's 50% of those who have unilateral disease, not due to an adenoma. If it's due to an adenoma, it's probably got a 2% recurrence rate. But it's still a significant recurrence rate.
Now, for sake of theoretical argument, I understand. I do agree with your message, overall message, that it's probably it's just as good enough. But let's say if one were to design a prospective randomized trial, either they go for adrenalectomy based on or therapy, in intention to treat methodology, you will always find some patients who are going to be non-compliant, not take the medication, get gynecomastia. So at the end of follow-up in a prospective trial, one can, not per protocol analysis, in intention to treat analysis, one can theoretically make an argument that if I can, surgery doesn't need that kind of a compliance over 20 years versus medical therapy does require that, provided per protocol, best treated analysis will show the equal outcome.
Absolutely. Absolutely. Yeah, 100%. Clinical trials can be tough. And in my evaluation, I take this and the age and health status of the patient affects how strongly I recommend going for an adrenalectomy. Okay, you're 82 years old and you got COPD and hand-to-mouth disease. I tell you can do it, but I suggest maybe you don't want to have surgery. You're 42 years old. I try to push you into. Yeah, I try to encourage you for the long term.
Now, the patients who had adrenalectomy, you know, like we discussed before, that they also have 50% chance of having contralateral disease develop later. Was that taken into account? Were they checking the PRA levels in these patients and IBU levels?
We can tell. Great question. Again, let me reemphasize. If an adrenalectomy, chance of recurrence appears to be strongly correlated with the CYP11B2 staining. If it's an adenoma, it's about a 10%. If it's not an adenoma, it's nodules or micronodules, that appears to be 50% recurrence rate. Now, that's based on one study out of Mayo Clinic. That's only
you might
I can look at that. They did not take that into account. From what I can tell, that most people, once they do an adrenalectomy and they confirm that it is pure, they stop following function. And I've taken the policy that every patient should be followed for the rest of their life, because it seemed to me that if it happened once, it could happen again. I've not yet had a patient have recurrence that I diagnosed.
She's 45 now. She had adrenalectomy probably 5-7 years ago. They turned it out the gland. She's a spironolactone now. Doing fantastic.
Great.
Very
All right.
compliant.
I have more, but I don't have any more time. Thank you very much for your attention. I'll stick around for any other day.
Okay, one question. Has anybody shown, and this almost smells like what you are saying smells like hyperparathyroidism. Has anybody shown relation to the clotho and these sort of these aging genes and these behavioral changes or special the changes in the aldosterone micromolecular pattern and stuff like that? Like, are these genes dependent on some of the aging genes, which are sort of making it appear? And then there is a whole phenotype of normotensive micronodular.
Great question. Who've done the genetic sequencing? They normally used a targeted approach. I haven't seen plot on the gene in. That's a good question.
And you have the whole bank.
What?
You have the whole bank, right?
Why?
Well, yours is a kidney bank.
I have a kidney. That's just what's done. I have genetic acquired genetic mutation. I have a lot of tissue.
I see.
It's substantially more expensive and complicated.
And this would this be reflect like your CYVP mutation, which is basically discerned? Would there be a way to pick it up in the blood? So it's essentially a pathological histopathology.
The cell next to it doesn't have the expression does not have the genetic mutation. In the testing, they compared the normal adrenal gland with the abnormal gland on the same gland. And it's acquired. This is not a somatic. It's not a mutation you were born. It then eventually resulted in.
So there is no marker that you can take it from your MVP data set to say that whether this is happening or not. It's no.
Should I start seeing the patient?
Good.
Patient, the first one?
It's interesting.
I'll see you.
Society of Endocrinology put out
Welcome.
guidelines last year and
Okay.
suggest all patients with
How are you?
hypertension be screened. Very similar to what you're saying. You spoke a lot about the 24-hour urine aldosterone. Why do you use that
Oh,
to
yeah, just.
I do
evaluation process?
almost never.
Oh, okay, all right.
No.
Okay, I was gonna say, I've never used it, rarely, it's just curious.
I use when I've looked at all the trials and I've said. And with my belief that this is a continuum out of the compass.
Right, great, yes.
That I don't need to make a definitive diagnosis. I just have and so I see if somebody has a suppressed renin
Mhm.
and non-suppressed aldo, and we don't have hypercumin,
Okay,
I call that autonomous aldo production.
and what's your definition of suppressed renin?
I normally see less than 0.5.
Oh, okay,
Okay.
okay,
And so I feel much more uncomfortable with this simplistic approach.
yeah,
If it's between 0.5 and 1,
okay.
and then I would start looking at the aldo-renin ratio.
Mhm.
But there, I went by very high from this aldosterone.
Yeah, sure.
But to me, the hard one and much more frequent is the renin is suppressed, the aldo is not elevated. And so I call it a not suppressed aldo.
Yeah.
I call it as 10 or more.
Okay,
I click these are simplistic, pulled it out of the air, suppressed aldo is less than 5.
suppression, okay,
Between 5 and 10 is indeterminate. It's
Okay.
indeterminate. I repeat it and I consider doing the 24-hour urine to get more data.
okay, interesting,
So
that's good. I've always used the kind of line in the sand, and I know it's arbitrary and patients are different, assays are different, but the renin level of wine. And then there's 0.5, and that's what the 2025 guidelines use as well. But the 0.5 is for those patients I'm gonna go down the road of possible adrenalectomy, vein sampling, because they seem to have a higher pretest probability of those patients with a high ratio greater than 20 and renin less than 0.5.
the issue that I have is that how do I, well,
Does that make
if
sense?
the
Or
renin is very suppressed,
correct?
the reason I do it this way is that the renin is very suppressed. I cannot calculate the aldo-renin ratio because it's being driven by the low renin.
Sure.
And so a patient, I diagnosed somebody with little syndrome 2 weeks ago. She had an aldo of 5, repeated it was 4, and plasma renin that was 0.1.
Sure.
Okay?
Yeah.
She looked at the report from the laboratory, the aldo-renin ratio. which was 40/50.
Okay.
She went online, she said, "I've got primary aldosteronism, why aren't you treating for primary
Sure,
aldosteronism?"
sure.
And so the problem comes with the analysis.
Like-
If the renal is very suppressed, you can't use the ratio. If the renal is from 0.5 and one, then they can use the ratio. And more questions ahead, and I want to see.
Should preface this with, there's patients who have a high pretest probability who's resistant hypertension and hypokalemia rather than,
Right.
yeah, okay.
Yeah.
Yeah, sorry, I don't want to keep it from clinic.
No, I apologize.
It's gonna be a long afternoon.
It's gonna be a long afternoon. Yeah.
But I appreciate the talk, very good. It's a great topic.
Hey, Dr. Weiner,
There.
I ran behind you yesterday, but I missed it.